Okay, thank you, Mark, for the kind introduction. So, implant dentistry has really revolutionized the way that we can restore aesthetics and function for our patients. However, with emerging techniques and materials, it's important that we continue to critically appraise the associated evidence so that we can optimize predictability and success for our treatments. Today, I'd like to present a case which showcases how we can leverage evidence-based dentistry in implant therapy. So this is our patient. He's 73 years old and he presents to my emergency clinic and tells me his upper right tooth is painful and biting. Medically, the patient is healthy, only taking rosuvastatin for hypercholesteremia. He's also a non-smoker. When I ask him about the tooth, he tells me it's mobile, it's keeping him up at night time, and he's having to take pain relief for it. On clinical examination, the tooth is grade 2 mobile, it's tender to percussion, and there's also a buccal swelling present. When I take a radiograph, I can see that there's a crown root fracture, and on bone sounding, there's significant bone loss on the buccal aspect of the tooth. Elsewhere in the mouth, the tooth 2-2 also has a chronic draining abscess, and this tooth is actually treatment planned for an apicectomy in 2 months' time. The patient also has a number of other missing teeth in his mouth. So I diagnosed the tooth 1-1 with a crown root fracture, which are deemed as unrestorable, and the patient tells me that he's previously had an upper partial denture that he wasn't able to adjust to and requests that we look at implant replacement for this tooth. So we know the tooth needs to be extracted. The question then becomes, how do we stage any implant treatment if we decide to do implant treatment at all? So there are a number of considerations when making this decision. Firstly, we have a significant bone loss on the buccal aspect of the tooth, which we know increases the risk of aesthetic complications with immediate implant treatment. Secondly, this is the first time that we're seeing the patient, so we've yet had the opportunity to perform prosthodontic treatment planning. So taking into consideration these two factors, I deemed immediate implant placement not suitable in this case. We also have to take into consideration the 2-2 apicectomy that's planned in 2 months' time, which may have also complicated the timing of any early implant treatment performed. So in this case, I decided to perform alveolar ridge preservation and aim more towards standard implant placement, knowing that this would minimize the dimensional ridge changes in this region. So when it comes to alveolar ridge preservation, there's yet to be an ideal technique defined in terms of how this should be performed. And additionally, alveolar ridge preservation in sites with significant amounts of buccal bone loss have been seldom investigated. So in other words, what this meant was that I needed to tailor my surgical approach to the patient's clinical presentation. A number of studies have looked at flapped versus flapless alveolar ridge preservation and have generally found that both clinically and radiographically, there doesn't seem to be a significant difference in terms of dimensional ridge changes between a flap or flapless approach. So in this case, where there's the likely need for improved access for proper positioning of the membrane, I decided to raise a flap for improved access and perform the alveolar ridge preservation with more of a GBR approach. When it comes to grafting material, we now have a large range of grafting materials available with different specifications in terms of osteogenic properties, osteoinductive properties, and also their resorption rates. A recent systematic review by Villa Ortiz found that investigating different approaches for alveolar ridge preservation found that the use of a xenogenic or allogenic bone with a collagen membrane produced the most favorable outcomes. Additionally, a network meta-analysis performed by Canalys in 2021, which allowed indirect comparison between different materials, also concluded that xenograft materials were one of the more favored materials for alveolar ridge preservation. Consequently, in this case, I utilized deproteinized bovine bone material with a collagen membrane. In terms of provisionalization or temporization of the patient's anterior tooth, he opted not to have the tooth replaced. So these are the photos of the alveolar ridge preservation performed as planned. So at this stage, I completed acute management of the patient's tooth 1-1, and the patient then subsequently returned 3 months later for definitive treatment planning. Medically, there were no major changes to the patient's medical history. However, at this point, the 2-2 apicectomy had been completed. And these are the patient's clinical photos from the treatment planning appointment. Thankfully, for the most part, we could see that the buccal contour as well as soft tissue height had been preserved. Periodontally, the patient had no deep probe and pocket depths, and full mouth plaque and bleeding scores were under 20%. And we could see that the 2-2 chronic abscess had also resolved after the apicectomy. Overall, we can see the teeth are heavily restored and worn. This is the patient's OPG, a little bit older, but it gives us a good overview of the patient's dentition. We can see that there's been minimal tooth loss in the mandible. We have impacted the lower third molars, and there's also a mucus retention cyst in the left antrum. And this is the CBCT taken at the treatment planning appointment, and for the most part, we can see that there's consolidation of the graft in this one site. So the patient has multiple missing teeth in the maxilla. We have a 2-2 crown with poor aesthetics, heavily restored and worn dentition, and we also classified the patient as with having periodontal stability consistent with more recent case definitions. So in planning for replacement of the patient's teeth in the maxilla, there's two main options that are available to us, either to fabricate a new upper partial denture or a fixed option involving some implants. When considering our upper partial denture, we have the tooth 17, which has loss of periodontal attachment and is also mesially inclined, which means that it's difficult for us to create a guide plane around this tooth. The tooth 25 is also heavily restored, and as well as being a lone standing abutment adjacent to a distal extension for a potential upper partial denture. Consequently, I deem these teeth as poor denture abutments. When considering the patient's suitability for implant treatment, he's medically fit, periodontally stable, he's a non-smoker, and he's also performing adequate oral hygiene. Consequently, I deemed him an adequate candidate for implant therapy with a low risk of biological complications. And together with my prosthodontic colleague, we planned a fixed bridge in quadrant 2 and 3 single unit implants. So after discussing both the pros and cons of the treatment, the patient opted to proceed with the fixed implant treatment option. And this is our final treatment plan. Full mouth rehabilitation, including a bridge in quadrant 2, 3 single unit implants, and a number of crowns and composite restorations, as well as 12 monthly supportive periodontal and peri-implant care consistent with the patient's risk profile. In placing the 1-1 implant, we plan to place this 4 months after the alveolar ridge preservation, utilizing a 12mm bone level implant. For the 1-6 implant, we plan to place a 10mm implant in this site and noted that we needed to perform guided bone regeneration due to the reduced ridge width in this site. And we plan to do this with deproteinized bovine bone material and a collagen membrane. So specific to the 2-6 site, there's also the issue of the sinus. So the residual ridge height in this site is approximately 6mm. We also have the issue of the sloped sinus floor and a mucus retention cyst. In the management of this, we have 3 main options available to us: either to use a short implant, perform a lateral window sinus lift, or a transcrestal sinus lift. When assessing the patient's suitability for a short implant, a systematic review published by Thoma in 2015 concluded that there is predictably high implant survival rates for short implants. However, this review only included randomized control trials with a follow-up of up to 18 months. And furthermore, most of the restorations were splintered in the included studies. A more recent systematic review concluded that there was good survival up to 3 years, however, conceded that the long-term effectiveness of short implants remains to be further studied. So in this case, I opted not to use a short implant, instead using a standard length implant and then having to make a decision between either a lateral window sinus lift or a transcrestal sinus lift. When making a decision between these two options, studies have generally shown good survival long-term for both of these options. However, we also have the issue of the sloped sinus floor in this case, which increases the risk of perforation when performing a transcrestal sinus lift. And although the long-term consequences of perforation are still debated and controversial, there is data to suggest an increased risk of failure as well as chronic sinusitis with membrane perforation. Consequently, I opted to not proceed with the transcrestal sinus lift and instead performed a lateral window sinus lift. When assessing the sinus, overall, there were no anatomical impairments or pathology associated with the sinus, but obviously the mucus retention cyst. And we know that mucus retention cysts don't represent absolute contraindication for sinus augmentation, provided that the procedure is not predicted to interfere with the osteomyelial complex. So what I decided to do was perform the lateral window sinus lift with no specific management for the mucus retention cyst, perform it with simultaneous placement of the implant considering the residual ridge height and utilizing deproteinized bovine bone material with a collagen membrane. So we completed the treatment planning, and at this stage, I was confident to proceed with surgery. So these are the photos of the 1-1 implant. We can see slight fixture exposure in the coronal region of the implant, and consequently, I performed additional guided bone regeneration, again, utilizing DBBM and a collagen membrane. These are the photos immediately post-operatively and at the 2 weeks post-op. For the 1/6 implant, these are the photos, again, with the implant placed as planned, with guided bone regeneration for contour augmentation. And again, the photos immediately post-operatively and at the 2 weeks post-op. And the 2/6 implant was also placed uneventfully with the lateral window as well. And again, utilizing DBBM and a collagen membrane to cover the window. And these are the photos immediately post-operatively and at the 2 weeks post-op. So the patient then returned 3 months after the implant placement for second stage surgery, and these are the photos at the time, as well as the corresponding radiographs. My prosthodontic colleague was then able to provisionalize the implants, and then again we have the radiographs at this stage of the therapy as well. I then was able to see the patient 12 months after for a 12-month review, and at this point the patient had all the definitive restorations completed. And again, these are the radiographs at that point in time. So just an overview of the patient's progress. This is where we started from with the missing 1-1 and acute management, and then the photos at the provisionalization and the 1-year follow-up. Okay, so I'm sure we all spend a good deal of time mulling over our patients' records and scans, reading a lot of literature, but at the end of the day, sometimes, just as Taylor Swift says, just because you made a good plan doesn't mean that's what's going to happen. And however, I do believe we owe it to our patients to at least be comfortable with the scientific rationale of our surgical approaches. Thank you.